Thank you so much for the kind introduction. Good afternoon, everybody, and I'm very thankful to the organizers for calling me here. So I'll be dealing with the recent updates in PCOS. And as we all know, Polycystic Ovary Syndrome or PCOS is the most common endocrine disorder affecting women. The prevalence varies from country to country, according to ethnicities. But if you look at the three pillars, we know it's hyperandrogenism, insulin resistance, and anovulation. Now, this insulin resistance, hyperandrogenism, and anovulation, the problems in GnRH pulsatility, all of these, as we know, are very closely intertwined. Now, what triggers what is like asking the chicken and egg question. Nobody knows that clearly, but we know there is a lot of contribution from genetics, epigenetic changes, and multiple environmental factors are becoming more and more prominent as triggers to the pathogenesis of PCOS. When we were students in endocrinology, we used to read the 2013 Endocrine Society guidelines, and this is possibly the only guideline that has been declared as retired by the society itself. And in 2018, the International Task Force based guidelines of PCOS came out, which was endorsed globally by almost all prominent endocrinology as well as gynecologic societies across the globe. And this was recently updated last year, which makes my job easier as I will just be highlighting the changes that have occurred between the two. So let us look at two hypothetical cases. This is the tale of two sisters, a 25-year-old lady, obese, having a sedentary lifestyle, having oligomenorrhea since her menarche, on and off combined OCPs prescribed by some doctor or the other, having increased facial hair, which is concerning to the patient, and a family history of diabetes. And this is her sister, her younger sister, 21-year-old, non-obese, more or less an active lifestyle, having oligomenorrhea for the last 5 years, increased hair over her face as well as to some extent on her body, as well as having refractory acne on her face. And again, of course, they belong to the same family, so they have a family history of type 2 diabetes in their parents. So, as we know, talking of the diagnostic criteria, these are the three criteria we all read about, but more or less it has been accepted that the Rotterdam criteria is the criteria to be followed. This is almost accepted everywhere now. And so any two of oligoanovulation, hyperandrogenism, and imaging detection of polycystic ovarian morphology after the exclusion of common secondary causes like thyroid dysfunction, hyperprolactinemia, and some of the other endocrine disorders that can mimic PCOS to some extent. So talking about anovulation or oligoovulation, so before we declare somebody as having oligomenorrhea, it's important to understand what a normal menstrual cycle interval constitutes for that particular age group. So between 1 to 3 years post-menarche, anything between 21 to 45 days would be normal. Before that, irregular menstrual cycles cannot be officially defined. After 3 years, after menarche, till the perimenopausal age, anything between 21 to 35 days is normal, and anything more than 8 cycles in a year is normal. And in more than 90 days for any one cycle would constitute as an abnormal menstrual interval, and any patient after 1 year of since menarche. So ovulated, the new guidelines state something that we often commonly practice, though it's in a different context, but that it has mentioned that ovulatory dysfunction can still occur in patients with otherwise regular menstrual cycles, and therefore it's important to document anovulation with mid-luteal serum progesterone. Now, this is something which we sometimes do to document whether a patient is ovulating or not, but this has now come in the guidelines as well. We know about the different phenotypes of PCOS, and though there is a lot of overlap between these, but phenotype A and B, as you know, they are more severe with greater cardiometabolic risk, and obesity and ethnicity can have strong modulating effects on these phenotypes. A number of genes have now been identified as contributors to the pathogenesis of PCOS, But all this together counts to less than 10%, explains less than 10% of the heritability of PCOS. It's otherwise having an autosomal dominant inheritance but variable penetrance. This is why all members in a family do not have PCOS. Now, depending on the genetic and some of the epigenetic findings, some guidelines have divided PCOS into different clusters, the reproductive group, the metabolic group, but the majority belong to the intermediate group having features of both of these. Now, coming back to the tale of our two sisters, so after having documented oligomenorrhea in them, the next clinical findings that we need to document is the presence of hirsutism. So hirsutism, as we all know, we objectified it using the modified Perelman-Galvez score, but the recent guidelines, although we use a cutoff of around 6 for most patients, but as per 2023, the cutoff should vary as per ethnicity and also the age of the patient, anything between 3 to 6, depending on the ethnicity and age, the different cutoffs we have proposed. But of course, this score has many fallacies, like it does not account for how patient important it is, it could miss some of the important areas, it's sort of subjective, and most of our patients would have undergone some form of cosmetic therapy before they come to us, especially if it is on their face. Apart from hirsutism, the other clinical markers that we should at least look for is a female pattern hair loss and acne, both of which, however, are weak predictors of biochemical hyperandrogenism, not so much as hirsutism. And for the female pattern hair loss, two visual scales do exist, Ludwig and the Olsen scale, but again, we do not routinely do this, but they do exist. For acne, however, no typical scoring system is there, but if it is a persistent or refractory or late onset acne, if there are more than 10 lesions on the face, and if they are unresponsive to the usual topical therapy, definitely they require investigation for hyperandrogenemia. Now for the obese elder sister, the modified Perelman-Galvez score was 4, and for the younger non-obese sister, it was 8. So what about biochemical tests? So biochemical tests to document hyperandrogenemia, it is useful only when clinical signs are unclear or absent. So somebody having overt hirsutism do not really need to undergo biochemical tests unless and until we are thinking about some secondary causes that would contribute to it. So in the last guidelines, they had only mentioned using calculated free testosterone or free androgen index. But we all commonly practice doing total testosterone, and we do not use the formulas to calculate free testosterone. This is reality. But the total testosterone again should be by the LCMS-MS method, not commonly available. We are doing immunoassays. It's still reliable, but the free testosterone immunoassays have a lot of fallacies, and it's not recommended. If we have to do free testosterone, it should be calculated from the total testosterone and SHBG. As we all know, testosterone should be measured for regularly menstruating females between day 2 to day 5, but if she is having anovulatory cycles, it can be any time. No clear cutoffs exist, but a total testosterone value of more than 55 nanogram per dl or free testo of more than 9 picogram per ml or a free androgen index of more than 4.5 are the usually accepted cutoffs. And there is no role of repeated androgen testing to monitor response to therapy in patients with PCOS. Androstenedione and GRs, they are not routinely to be done, but if the testosterone and free testosterone are not elevated and we are having a strong suspicion, then we need to look at this. Of course, we should not forget about the different differential diagnosis of PCOS, all the endocrine causes of gonadal hyperandrogenism, like any adrenal tumors, ovarian other steroid-related blocks that could contribute. Adrenal hyperandrogenism, again, some forms of congenital adrenal hyperplasia or tumors, and some other peripheral causes of course. And so, if a patient, for a patient with PCOS, we do expect a mild to modest elevation in testosterone. If it is more than 200, there should be a suspicion for androgen-producing tumors. And the DRs, again, we expect a modest elevation. If it is more than 700, as we all know, we have to have a suspicion for adrenal tumors. And for somebody who is non-obese, who is young and having a strong family history, having more significant hyperandrogenism, we might be missing out the diagnosis of non-classic CAH. And for such patients, the 17-hydroxyprogesterone levels of more than 2 would constitute the diagnosis. Now, since we're talking about recent updates, for the last few years, a lot of discussion has been happening on the other pathways of androgen biosynthesis, which might be more important in PCOS rather than the classic pathway, like the backdoor pathway, the the C11 oxy pathway. I don't know why the bottom part of the slide is not coming, but the C11 oxy pathway is possibly the most important pathway of androgen synthesis in PCOS. And rather than testosterone, there are studies suggesting that 11 oxygenated androgens could contribute to the majority of circulating androgens in women with PCOS. Especially 11 testosterone is an upcoming biomarker for PCOS. As is also salivary testosterone, which has been found to be as predictive as free androgen index for the diagnosis of classic PCOS. LH-FSH did not really have much role in the diagnosis of PCOS, may be used as adjunctive test in non-obese PCOS with no clear cutoffs existing. So coming back to the two sisters, the elder sister obese with a Ferriman-Gallagher score of 4, the testosterone was 58, total testosterone, and free androgen index was also high. For her non-obese younger sister, the Ferriman-Gallagher score was higher at 8, as was the total testosterone. For her, actually speaking, the measurement of testosterone was not clearly indicated, but we did do a total testosterone and we asked just to rule out any tumors because she was having more florid hirsutism and other features of androgen excess. However, the values were not in the range of tumors. She was non-obese, LH-FSH was done and LH was higher than FSH, but as said, there are no cutoffs existing for these. Again, coming to imaging, we all do an ultrasound to diagnose PCOS, of course, but if you look at the recent guidelines, it clearly mentions it is not required in patients with having a clear history of clinical features of hyperandrogenism along with oligomenorrhea. If we are to do imaging, we look at ovarian volume, FNPO, which is follicle number per ovary, and as per the recent guidelines, more accurate than the follicle number per ovary is possibly follicle number per section because it is a two-dimensional test and it is not to be used in adolescents. Ultrasound is not to be used for diagnosing PCOS in adolescents. So the recommended parameters for diagnosing, if we look at this, the follicle number per cross-section, it has better sensitivity and specificity as compared to ovarian volume. A number of other parameters have also been tried. We still, as part of our routine practice, we write about stromal hyperechogenicity, stromal thickening and all, but these have been found to be not very accurate in the diagnosis of PCOS. Stromal strain ratio is, however, an upcoming marker. So coming back to our patients, so the first elder sister, obese oligomenorrhea, having biochemical hyperandrogenism. So truly speaking, she was not dialed in necessity for an imaging diagnosis, as was also her younger sister, having clear-cut picture of oligomenorrhea, hirsutism, and biochemical hyperandrogenism. However, we did do an ultrasound. In the obese sister, it was improper, the pelvic organs were not properly visualized due to fat. We commonly see that. The younger sister, the ovarian volume was 16 cc bilaterally along with polycystic ovarian morphology. Talking about anti-Mullerian hormone, very much in discussion nowadays as a test to be used in the diagnosis of PCOS. So yes, it is secreted from the pre-ovulatory follicles, so it is high in PCOS. And what this excess AMH does is inhibit FSH-induced ovulation, aromatase expression, as also decreases insulin-promoted aromatase expression, causing lesser of estrogen formation and contributing to the hyperandrogenism. Not only is it increased in women with PCOS, not only is a biomarker for PCOS, but it can effectively predict ovarian response during controlled ovarian hyperstimulation. So our chairperson, gynecologist will be in a better position to explain this. But the advantage that AMH has over other tests is that there is lesser of menstrual cycle variation. So it can be done at any time of the menstrual cycles. So different cutoffs have been proposed for AMH as a marker of polycystic morphology, hyperandrogenism, or oligomenorrhea, but only if it has been found to be a good alternative to PCO morphology, that is imaging evidence, not for hyperandrogenism and oligomenorrhea, just because of lack of robust data. The cutoffs are different, but as an alternative to PCO morphology, 4.1 nanograms per ml is the cutoff that we are accepting for AMH. So in the 2018 guidelines, AMH did not really have a place. The 2023 guidelines, it clearly states AMH could be used for defining PCO morphology, not PCOS, but PCO morphology only in adults, but it should not be used as a single test. So for the elder sister with not so clear-cut picture of PCO morphology and ultrasound, AMH was done, which was actually higher than the cutoff of 4.1. For the non-obese younger sister who was clearly having polycystic ovarian morphology on imaging, AMH was not included. Talking about metabolic parameters, till 2018, PCOS along with additional risk factors like smoking, obesity, dyslipidemia, only they were considered to be having a high CV risk, and only overweight and obese PCOS was indicated to do a fasting lipid profile and other CV risk tests. But as we all know, even non-obese PCOS have equivalent cardiovascular risk possibly, and therefore all PCOS patients should be considered to be having high CV risk and be screened for additional CV risk factors. And PCOS in isolation, PCOS alone, should be included in CV risk prediction tools. Talking about diabetes screening, in the last guidelines it was only for the high risk PCOS, and either fasting or OGTT or HbA1c could be used, but OGTT only for the high risk cases. But again, as per the last guidelines, all PCOS cases should undergo testing for dysglycemia and preferably with an oral glucose tolerance test rather than fasting or HbA1c. And there is no role of measuring insulin either for the diagnosis or for the monitoring of treatment of women with PCOS. Even if we get a clear picture of insulin resistance or we do not have any picture, insulin assays are not indicated in the diagnosis or management of PCOS. Of course, we should also look for the other risk factors like the risk of obstructive sleep apnea, metabolic dysfunction associated with steatotic liver disease, osteoporosis, and endometrial cancer risk. We all know, but we need to counsel our patients regarding these risks as well. So coming back to our two sisters, both the obese and non-obese sisters, both of them have to undergo anthropometry, metabolic risk screening along with psychosexual assessment. Coming to the management part, as you all know, lifestyle modification still constitutes the pillar of management of PCOS. It is the first line therapy for obese as well as non-obese PCOS. And talking about changes, only thing that has changed regarding the exercise duration for maintenance of body weight and good health. So it was only 150 minutes moderate intensity last time, and it has increased to 300 minutes. So of course, the more you exercise, the more you do aerobic exercises, the better it is. And talking about treatment, pharmacotherapy, combined oral contraceptive pills remains the first line both for hirsutism as well as for oligoamenorrhea. No specific recommendation regarding any particular formulation or any particular dose, but yes, we should use the lowest effective estrogen dose, preferably those containing 20 micrograms of ethinyl equivalent. Many of us still use progesterone only OCPs, and it was not there in the last guidelines, but thankfully our teachers have taught us that it can be used. Possibly it was there in some guidelines 30 years back, and it has again come in the recent guidelines. So progesterone only oral contraceptives can be considered in patients where only endometrial protection is desired. So somebody having only oligomenorrhea, no clinical or biochemical hyperandrogenism, no metabolic risk factors, there may be a case for given only progesterone only OCPs. Metformin monotherapy, of course, we can give it in adults with PCOS or obese or having IgD, but as per recent guidelines, it also can be given in adolescents at risk and non-obese adults. The maximal dose being 2.5 gram in adults and 2 grams in adolescents. Combination of COCPs and metformin is not superior to COCPs plus lifestyle modification and comes with additional GI side effects of metformin. Can be considered in those who are really very obese and having impaired glucose tolerance or other multiple risk factors for diabetes. When we are using a combination of COCPs plus anti-androgens for hirsutism reduction, we are going to add the anti-androgen only if there is no reduction in hirsutism of with COCPs after 6 months of therapy. And it's important to explain the side effects. Spiral reduction, we all of us know underutilization of male figures, that's why we do not use it alone without COCPs. But for cyclotron, there is small but genuine risk for meningioma, and of course, finasteride and symptomide, high risk of hepatotoxicity is there. So for the obese elder sister with impaired glucose tolerance, she was started on metformin along with lifestyle changes, and for the non-obese younger sister, lifestyle changes along with COCPs was given. A lot of discussion over the past 2-3 years on anti-obesity pharmacotherapy in PCOS, focusing on GLP-1 receptor agonists mostly. We have a lot of evidence now in favor of liraglutide, semaglutide, as well as exenatide in PCOS without diabetes, and they have been found to be effective mostly for the metabolic and anthropometric parameters, with insignificant effects, however, on the androgen levels. But as you all know, insulin resistance and hyperandrogenism are closely intertwined, so maybe if the study was to extend for a few months more, we could have seen effects on the androgen levels as well. For orlistat also, few studies but remarkably good results. And recently we published a systematic review of SGLT2 inhibitors in PCOS, and again we found that IMPA, CANA and JAPA, as compared to metformin, the DR's reduction was more significant, whereas the reduction of testosterone was similar to metformin, and when used in combination with GLP-1 RAs, SGLT2 inhibitor plus GLP-1 RA in PCOS without diabetes was very good for the metabolic and anthropometric parameters, whereas the SGLT2 inhibitor metformin combination showed better effects on the hyperandrogenism part. Bariatric surgery, yes, it is indicated in the very obese patients, and possibly if the patient is having PCOS, it is important to lower the BMI cutoffs to consider bariatric surgery. And since it leads to rapid return of fertility, the need for contraception is to be explained very clearly to the patient, because we know the patient has to wait for a certain period of time after bariatric surgery before she becomes pregnant to avoid the hassles of micronutrient deficiency on the fetus. So the elder sister, obese, not responding properly to lifestyle changes and metformin, possibly GLP-1 RAs could be a good option to add in her. And the younger sister with no significant results on her hirsutism, apart from lifestyle modification and 6 months of combined OCP, we could add one spironolactone in her. Ionositols, as we know, they are also being increasingly used with very good results, because it can take care of both the insulin resistance as well as the FSH signaling parts, has shown very good results in improvement in insulin resistance, menstrual frequency, hyperandrogenism reduction, as also reducing the incidence of gestational diabetes and preterm births. So 2018, it was considered an experimental therapy. 2023 clearly says inositol in any form should be considered in treatment with PCOS for improving both metabolic parameters as well as hormonal parameters. But what we clearly do not know is what form, what ratio of is to dechloroinositol, and how long to monitor dose titration. There are many unanswered questions as of now. So for the now both of these sisters are now planning conception. So what next? Of course, we stopped the spironolactone, OCPs, GLP-1 RAs, whereas continue the lifestyle modification, metformin and possibly inositol. Preconceptional checkups for glycemic status, blood pressure, thyroid is very important. Now, they do not conceive spontaneously in 12 months after all of these. What next? So as you know, pregnancy in patients with PCOS confers a very high risk for gestational diabetes, miscarriage, hypertension, and so many other things which we all know. So there is a very dire need for preconceptional as well as early pregnancy checkups for his glycemia, blood pressure, and body weight as well. And ovulation, talking about ovulation induction agents in PCOS, all of us know letrozole followed by clomifene cyclopentformin combination, followed by clomifene, followed by metformin alone. And so both of these sisters were given letrozole. So the first obese sister, she did not have any good response after 6 cycles. The non-obese younger sister conceived within 3 cycles of letrozole. So what has changed is the second line after letrozole. So in 2018, gonadotropin therapy was the second line in women with PCOS who failed first line oral OI therapy, which was letrozole or clomifene or metformin or combination. But 2023, they say gonadotropin should be considered over clomifene in treatment-naive women with PCOS. And of course, the low-dose step-up approach is to be used, but there is the risk of multiple pregnancy as well as ovarian hyperstimulation. Now, this is not my domain. I would refer this patient to an IVF specialist. But just to know that there are measures to reduce risk for ovarian hyperstimulation, which includes adjunct metformin therapy. Now, talking about metformin, whether to continue it or not during pregnancy, that remains a question. As we know, the diabetes guidelines recommend it should be stopped. But if you look at the PCOS guidelines, it says that it may be continued if it is otherwise indicated, because it does reduce the risk for preterm births and limit exceptional gestational weight in pregnant women with PCOS. So the first obese the elder sister, who failed with letrozole, she conceived with gonadotropin, failed with letrozole and gonadotropin. She conceived after 2 cycles of IVF, and the metformin was continued to her. And the non-obese younger sister, she was already 3 months pregnant by this time, but it's important to screen her for early GBM, that is in the first trimester itself. Another interesting finding is that it has been found that fathers but not mothers and brothers but not sisters of patients with PCOS will have a high risk for metabolic syndrome, which suggests that there could be a genetically defined ovary independent male cardiometabolic equivalent for PCOS. Talking about the menopause diagnosis in the perimenopausal age group, the recent guidelines acknowledge that PCOS is a lifelong diagnosis like diabetes, like hypertension. Only that if for patients presenting for the first time during menopause, it is important to rule out tumors and ovarian hypertrichosis as causes for the hypertension. Talking about diagnosis in adolescents, for diagnosing PCOS in adolescents, imaging is not to be used. There has to be the presence of both irregular cycles as well as hyperandrogenism. And when I talk about,
I think you need to continue.
Okay, sure. So the key updates is that biochemical hyperandrogenism, if it is to be used, it has to be using reliable assay methods, otherwise calculated free testosterone. AMH is a good surrogate. There is an emerging role of GLP-1 and inositol, and it is important to identify adolescents at risk for PCOS and re-evaluate the time. Thank you so much.